Assalamu alaikum. Let's talk about a very interesting topic called subarachnoid hemorrhage. A subarachnoid hemorrhage is an intracranial hemorrhage. So, what is subarachnoid hemorrhage? It is an intracranial hemorrhage that is defined as the presence of blood within the subarachnoid space. So presence of blood within the subarachnoid space, that means deep to the subarachnoid layer of the meninges. The most common cause is head injury. So trauma is the number one cause of this subarachnoid hemorrhage. In the absence of trauma, subarachnoid hemorrhage is termed as spontaneous subarachnoid hemorrhage. So without trauma, it is termed as spontaneous subarachnoid hemorrhage. If we look at the causes of subarachnoid hemorrhage, we can remember the cause like Marfan, AV malformation, arteriovenous malformation. There may be kidney disease like polycystic kidney disease. There may be Ehlers-Danlos syndrome, and sickle cell is one of the important cause of the subarachnoid hemorrhage. And apoplexy, pituitary apoplexy is another cause, and most important cause is hypertension. So hypertension, adult polycystic kidney disease, Ehlers-Danlos syndrome, coarctation of the aorta, AV malformation, apoplexy, and Marfan, and sometimes mycotic or infective aneurysm is one of the causes of these subarachnoid hemorrhage. What are its features? If we look at the presentation of the subarachnoid hemorrhage, there may be headache. It is the number one headache. A patient will tell this is the worst headache in my life. Maybe thunderclap headache or hit with a baseball bat like of headache. This is the worst headache of my life, and it may be occipital. It is headache is occipital, typically peaking in the intensity within 1 to 5 minutes. The intensity is within 1 to 5 minutes. There will be nausea, vomiting. Patient may come with coma, or patient may come with the seizures. So these are the presentation. And if we do ECG, ST elevation may be found. ECG changes including ST elevation may be seen. This may be secondary to either autonomic neural stimulation from the hypothalamus or e- elevated level of the circulating catecholum. And why this ECG showing ST elevation uh, when the problem is in the brain? It may be due to autonomic neural stimulation from the hypothalamus, or maybe due to increased circulating catecholamines, that means epinephrine or norepinephrine. Investigation is a very high yield. We know that non-contrast CT is the first line investigation for diagnosing this subarachnoid hemorrhage. And in a non-contrast CT, there may be acute blood, hypertension, bright red on CT, typically distributed in the where, in the basal. cistern, in the basal cistern, or in the sulci. In severe cases within the ventricular system. So we may get blood in the basal cistern, sulci, and in severe cases in the ventricular system. If CT scan is done within 6 hours, if CT scan is done within 6 hours, no LP should be done. If CT scan is done within 6 hours and is normal, according to the new guideline, no LP should be done. You should consider an alternative diagnosis. If CT scan is done more than 6 hours after the symptom onset and it is normal, then you need to do an LP, lumbar puncture. In an LP should be done at least 12 hours following the onset of the symptom to allow the development of the xanthochromia, xanthochromia. Xanthochromia actually helps to distinguish from true subarachnoid hemorrhage. Xanthochromia helps to distinguish from true subarachnoid hemorrhage from traumatic tap. So xanthochromia helps to distinguish in true subarachnoid hemorrhage from, if you find xanthochromia, that is true subarachnoid hemorrhage, and sometimes traumatic tap can be found. So for distinguishing traumatic tap from subarachnoid hemorrhage, we need to find xanthochromia. CSF findings consistent with subarachnoid hemorrhage include a normal or a raised opening pressure. If CT scan shows evidence of subarachnoid hemorrhage, if CT scan show subarachnoid hemorrhage, refer the patient to neurosurgery. You need to refer the patient to neurosurgery. After spontaneous subarachnoid hemorrhage is confirmed, that means it is not due to traumatic. The aim of investigation is to identify the causative pathology that needs to urgent treatment. Then, so if it is not due to trauma, if it is due to spontaneous subarachnoid hemorrhage, our aim is to investigate to find out the pathology. So we can do CT intracranial. So we can do CT intracranial angiogram to identify the vascular lesion and aneurysm or AVM with or without digital subtraction angiogram. So CT intracranial angiogram as along with DSA. So CT intracranial angiogram to identify the vascular lesion, aneurysm or AVM with or without digital subtraction angiogram. And we know the management, bed rest, analgesic, venous thromboembolism prophylaxis, discontinuation of the anti-thrombin, the most important to prevent vasospasm. To prevent vasospasm, we can give oral calcium channel blocker, that is oral nimodipine. An intracranial aneurysm are at risk of free bleeding and therefore it requires prompt intervention, preferably within 24 hours. Most intracranial aneurysm are now treated with a coil by interventional neurologist, and sometimes craniotomy and clipping by a neurosurgeon. And the most important, the complications, rebleeding can happen. Hydrocephalus, rebleeding hydrocephalus, and vasospasm, typically 7 to 14 days after vasospasm, also known as delayed cerebral ischemia, typically 7 to 14 days after the onset, and hyponatremia can happen due to SIADH and the seizure. So, rebleeding, hydrocephalus, vasospasm, hyponatremia, seizure can happen. Rebleeding can happen around 10% of the cases, most commonly within 24 hours. If rebleeding is suspected, then a repeat CT scan should be arranged. There is a high mortality, and if there is an hydrocephalus, is temporarily treated with an extraventricular drain, and sometimes VP shunt can be done in vasospasm, typically within 7 to 14 days after the onset. And the important predictive factor for subarachnoid hemorrhage is consciousness level on admission, age, and amount of the blood visible on the CT. And that is all about subarachnoid hemorrhage. It's a very important topic. Hope you enjoyed.